Hello, everyone. You are welcome to the Eastern Mediterranean and African webinar, Epilepsy Educational Webinar. It's really my pleasure to introduce our first speaker today. As you know, today we have two speakers, Dr. Anasoya and Dr. Ghaib. So I will start with the first speaker, Dr. Anasoya Nido. Dr. Nido is consultant neurologist, and she is the head of clinical unit in neurology at Gray Hospital. She obtained her MBCHP at University of Gazawati, Natal. Then she finished her fellowship of neurology at College of Medicine, South Africa. After that, Dr. Nido obtained Masters in Medicine Neurology at KwaZulu, Natal. Dr. Nido had multiple publications, and she had participated as a speaker in many international webinars and conferences. Dr. Nido is going to enlighten us today and talk about gut microbiome and epilepsy. So the mic is yours.
Thank you, Dr. Alvaradi, for that introduction. I'm going to start screen sharing and we can start our discussion for today. So good evening, everybody, or good day, depending on which part of the world you are in. So as you can see up on the screen, my presentation for today is I'm going to be discussing the gut microbiome and epilepsy. And I have to say, research into this and reading into this topic as best as I can, and I'm hoping that it will open a discussion on the topic after I present. So to start off with, in terms of the introduction, the human body is regarded as a sort of a mobile terrarium for other living things. So 99% of the genes in your body are not actually yours. Surprisingly, they belong to bacteria, viruses, fungi, and a multitude of other microorganisms which live almost everywhere on our bodies, from the mouth, the eyes, the nasal passages, but mostly in our gut. So given the blood-brain barrier, the idea that bacteria in the gut could influence the brain is a relatively hard concept to actually try to swallow. But what has been found is that there's a complex interplay that's undergoing between the gut microbiome, the brain, and the rest of the body. The gut and the brain are actually connected by specific neuronal circuits, and they're not as separate as we would think. From there, the term, the microbiota gut-brain axis, has been coined, and this can be called the gut-brain axis, the gut microbiota-brain axis, the brain-gut axis, whichever you want to call it, it refers to the same term. It describes the complex bidirectional communication pathways which link the central nervous system with the gut bacteria. And this system has become a focus of neuroscience in the last decade, with a considerable amount of funding being pumped into research around the topic. There's increasing animal and human studies which confirm that there is a communication between the gut and the brain, and confirms the role of gut microbiota within the central nervous system functions. But the exact mechanism of the axis is not yet fully understood. So just a little bit on epilepsy. I think this is a condition we are relatively familiar with. It's a chronic neurological disorder characterized by recurrent seizures. It can be classified into primary epilepsies, which are largely genetic, or secondary or symptomatic epilepsies, where there's an underlying lesional cause. The search for the cause of the epilepsy can be quite a challenge, and its treatment as well. Treatment modalities can be drug, surgical, or neuromodulation, but problems come about with a lack of response to therapy or the presence of side effects. And up to 1/3 of patients have drug-resistant epilepsy. Patients with drug-resistant epilepsy are unlikely to attain seizure control despite additional anti-epileptic drugs being added onto their therapy. And they face a multitude of problems ranging from issues with polydrugs to social, educational, and cognitive issues surrounding their treatment. Often, alternative therapies may be offered to them, for example, dietary therapies, but in essence, there have been few advances in the effective therapeutic management of drug-resistant epilepsy. With regard to the gut microbiome axis and epilepsy, the gut microbiome axis may actually shed light on epilepsy pathogenesis, as well as it may be able to identify particular targets for the intervention of epilepsy. Changes have been found in the composition or function of the gut microbiome, and this has been linked to both epilepsy and refractory epilepsy patients. And it's believed that gut bacteria may exert effects on seizure susceptibility or epileptogenesis. So what is the gut microbiome? This is a group of bacteria that is present in our intestine. It consists of trillions of microorganisms of more than 1,000 different species. It comprises bacteria, fungi, protozoa, yeast, viruses, and actually takes up about 1.5 kilograms of our body weight. But by far, bacteria are the most numerous species within the gut microbiome, consisting of approximately 500 different species of bacteria. It is unclear what a normal gut biome looks like, and it's thought that the gut biome may be as distinctive as a fingerprint in individuals, but it's more likely that there are variations on a theme. There are 4 dominant bacterial phyla in the human gut, with Firmicutes and Bacteroides being the most dominant phyla that are present. The composition of the core gut microbiota is formed during the first year of life, with babies receiving their critical gut bacteria from their mother during delivery. After 1 year of age, infants form a complex gut microbiome, just like adults. And what it's known is that gut microbiota is not fixed, and changes occur continuously throughout life and actually decrease with aging. Its composition can be influenced by host factors, age, physiology, environmental factors, dietary factors, delivery method, and dynamic changes are driven by stresses like infection, drugs, and diet. The common phyla that are present are Bacteroides, which have roles in carbohydrate metabolism and amino acid transport, and they are found abundantly in a healthy individual. What is known is that this phyla decreases with dysbiosis, which we will discuss a bit later. And Firmicutes, which is the other dominant phyla, also has a role in carbohydrate metabolism. This dominant species increases with dysbiosis as well as obesity. Other phyla are present in low levels in healthy individuals, but may be found in higher levels in patients with obesity or dysbiosis. So what is the gut microbiome axis? This is an axis or system which is capable of positively or negatively influencing brain functions through the activity of microbiota. It's a bidirectional communication, and there are 2 particular neuroanatomical pathways that are used for communication, and this is directly via the vagus nerve or indirectly through the enteric nervous system. It is a collective network which includes the gut microbiome, metabolic products, the enteric nervous system, the autonomic nervous system, the neuroendocrine system, the neural immune system, and the central nervous system. The functions of the microbiome are vast, and they can constitute a physical intestinal barrier. They stimulate intestinal cell regeneration. They produce mucus, which nourishes the mucosa, and also produces short-chain fatty acids, as well as they have an important role in the maturation of the immune system, particularly the innate immune system. They are responsible for the synthesis and metabolism of nutrients, hormones, and vitamins, as well as they provide a defense against pathogens. Prior to the last decade, studying of the gut microbiome was relatively limited, And this was due to limitations with culture-dependent techniques of the actual gut microbiome. The abundant microflora present in the gut could not be cultured. But newer technologies, which allow for sequencing methods and microbial characterization independent of culture, has allowed for microbiome profiling, as well as for metagenomic sequencing, which now allows for whole genome sequencing of the microflora, and has really contributed to our understanding of this axis. Gut dysbiosis, which I mentioned earlier, refers to a gut microbial imbalance. So alterations occur in the taxonomic or functional profile of the intestinal microbial communities which are resident within the gut. These are associated with the genesis or progression of a variety of neurological disorders. So how does the gut impact the brain? The gut microbiome affects the CNS physiology and neurotransmission through the various systems that I mentioned previously, through the immune system, the metabolic system, and the neuroendocrine system. The microbiome itself may promote synaptogenesis. They may activate a stress response, synthesize neurotransmitters, and have an impact on blood-brain integrity. The microbes stimulate inflammatory responses and immune defenses against external pathogens, and this results in release of cytokines. They also produce hormones and neurotransmitters, which are identical to those produced intrinsically by humans. Bacterial enzymes may produce neurotoxic metabolites such as lactic acid and ammonia, and even beneficial metabolites like short-chain fatty acids, GABA, and serotonin may exert neurotoxic and neuromodulatory effects on the central nervous system. Bacterial receptors to hormones may further influence microbial growth and virulence, and through these varied mechanisms, the gut microbes actually shape the architecture of our brain. So some of the gut metabolites that we should be familiar with are short-chain fatty acids. These have anti-inflammatory properties. They promote neuroinflammation, and reduced levels of short-chain fatty acids increase the blood-brain barrier permeability. Another neurotransmitter is GABA, which a bacterial dysbiosis can actually alter its levels. It's the major inhibitory neurotransmitter in the brain, and reduced levels of GABA may contribute to exacerbation of seizures. Cloudins are decreased in gut dysbiosis. They increase gut permeability, and their function is to seal and make the intestinal lining impermeable to compounds. When they are decreased, it results in the leakage of the intestinal lining with increased permeability to metabolites, microorganisms, cytotoxins, and cytokines. So the neuroanatomical pathways that are relevant to the system are in particular the autonomic nervous system, the vagus nerve, the enteric nervous system. And these three aspects of the nervous system communicate with each other. There's a hierarchical 4-level integrative organization which is involved in the gut microbial axis. This entails the enteric nervous system, which includes the myenteric ganglia, the subnucleus ganglia, and gut glial cells, the prevertebral ganglia, the autonomic nervous system, the brainstem, in particular the nucleus tractus solitarius and dorsal motor nucleus of the vagus nerve, and higher brain centers. A symbiotic relationship exists between the brain and the gut, with the central nervous system regulating the function and integrity of the gut through the neuroendocrine hypothalamic pituitary axis and the autonomic nervous system. Intestinal microbiota modulate the enteric nervous system, and the communication between the gut and the brain may occur by the production of the microbial metabolites, the activation of the vagus nerve, and the modulation of the endocrine and immune response. Other neurological conditions have been implicated in terms of their pathogenesis with the gut-brain microbial axis. In particular, Alzheimer's disease, Parkinson's disease, multiple sclerosis, autism, and anxiety and depression have all shown pathogenic links with animal models in terms of this axis and the brain. So there are a number of questions that we can ask in terms of a link between the gut and the brain. We can ask, what is the mechanism that gut microbia actually lead to changes in the brain? Is there an actual neural link? Do different bacterial groups create different metabolites which have different effects on the central nervous system? Do they lead to changes in the immune system? What is that effect on the brain? Could the gut microbiome actually act as a biomarker for epilepsy? Could it predispose one to developing epilepsy? Do people with epilepsy have different populations of bacteria? Does successful anti-epileptic drug treatment change the gut microbe? Does it play a role in epilepsy? Can it affect seizure frequency? Can populations of bacteria predispose to seizures? And more importantly, can we harness the power of this microbiome to stop seizures? So it's a multitude of questions, which hopefully I'll try to touch on in the following few slides. So epilepsy and gut dysbiosis. Dysbiosis of the gut microbiome and the frequency of epileptic events are often correlated. Animal and human studies support dysbiosis as a causative factor of refractory epilepsy. Most of the research to date is preclinical, but the results that are available are intriguing. Refractory epileptics tend to have greater alterations of their microbiota composition than drug-sensitive epileptics and when compared to healthy controls, and several pediatric studies actually demonstrate this. So can the microbiome modulate seizure activity? Now, there are various communication routes between the gut microbiota and the brain, which I've mentioned, that being the neural connections, the neuroendocrine hypothalamic pituitary axis, via neurotransmitters, the intestinal immune system, the connection between the intestinal mucosal barrier and the blood-brain barrier, and the influence and bioavailability of anti-epileptic drugs. So what is the actual pathophysiological link with gut dysbiosis and epileptogenesis? The first comes from a direct effect on neural networks through the release of neurotransmitters. Serotonin and its metabolites, GABA, dopamine, and glutamate, are released by gut bacteria. These affect the balance between excitation and inhibition within the central nervous system. Alterations in neurotransmitter levels, example GABA and glutamate, can be demonstrated in hippocampi in animal models. When GABA is reduced, the threshold for seizure onset is lowered. And many or most of our neurotransmitters in the body are actually generated by gut microbiota. The second potential pathophysiological mechanism is via neuronal signaling. Under homeostatic conditions, gut bacteria stimulate afferent neurons in the enteric nervous system via the vagus nerve. This induces an anti-inflammatory activity. But gut dysbiosis compromises this balance towards excess inflammation. The third mechanism is a decrease in the normal biosynthesis of short-chain fatty acids by gut microbiomes. So numerous short-chain fatty acids have been known to have an anti-inflammatory effect. But when these short-chain fatty acids are reduced, it may induce secondary neuroinflammation, which can trigger seizures. And in animal models, intestinal inflammation has been shown to induce convulsive activity. And when animal models are administered with anti-inflammatories, it's shown a reduction to seizure susceptibility and restores the effectiveness of anti-epileptic drugs. The fourth mechanism, sorry about that, looks at disruptions in the normal stress response, which alters gut microbiome. This modulates levels of brain-derived neurotrophic factor and influences seizure mechanism. In animal models, the griseofulvin mouse model shows significantly elevated corticosteroid and adrenocorticotropic hormone in response to mild stress. And this was reversed by fecal microbial transplant. Fecal contents of chronically stressed rats, which were transplanted into non-stressed animals, was shown that both stressed rats and unstressed rats with transplants from stressed rats had seizures sooner. Seizures tended to last longer when compared with controls, and conversely, when stressed animals received gut bacteria from unstressed animals, their seizure susceptibility decreased. The fifth and last mechanism is the leakage in the integrity of the barrier system, that is the intestinal mucosal barrier and the blood-brain barrier. The gut dysbiosis leads to an excess in lipopolysaccharides producing bacteria, and this increases the permeability of the intestinal immune barrier. There's upregulation of brain cytokines, and increased permeability of the blood-brain barrier, and pro-inflammatory mediators which enter the central nervous system. Again, in animal studies, it's shown that stress once again changes the intestinal mucosal barrier function, with cytokines entering the blood circulation and peripheral producing inflammatory factors increasing the permeability of the blood-brain barrier and thus directly influencing the brain. So if we look at post-traumatic epilepsy as a potential model, which we could look at the gut microbiome axis, what we find is that 50% of people who've sustained brain trauma will in later years develop epilepsy. So looking at the early microbiome changes after trauma, could we predict whether a patient would develop epilepsy later on? Traumatic brain injury is known to produce an abnormal functioning of the autonomic nervous system, and gastrointestinal dysfunction is one of the major manifestations of gut microbiome composition. This can trigger both peripheral and central inflammation, with gut bacterial toxins being introduced into the blood and elevated inflammatory markers in the peripheral system. These inflammatory events could be thought to promote the pro-epileptic effect of brain trauma and even precipitate epilepsy. It's a potential model to look at for research. The last area to look at is the drugs or anti-epileptics and whether they interact directly with gut microbes. So gut microbes can impact drug absorption, metabolism, and thus the efficacy or toxicity of anti-epileptic drugs. Anti-epileptics can be transformed to either their bioactive, inactive, or toxic metabolites by microbia. And zonisamide and clonazepam are drugs which are actually metabolized by gut microbes. Lamotrigine itself may inhibit growth of certain gut microbes, and animal studies have shown interactions between anti-epileptic drugs and the gut microbiota. But overall, the microbiome studies in epileptic patients to date are few and they are underpowered, and their focus tends to be on the bacterial taxonomy rather than the function of the anti-epileptic drug itself. And it's uncertain at present whether the microbiome composition actually does alter drug serum levels for anti-epileptic drugs. So how can we modify the gut microbiome to aim to restore gut dysbiosis in patients where there are alterations in the microbiome? So potential modalities include dietary modifications, for example, the ketogenic diet, antibiotics, pre or probiotic supplements, fecal transplants, and these may all represent potential therapeutic approaches in treating epilepsy. The gut biome can be altered in many ways, starting even before birth. At birth, the mode of delivery may result in a different composition of an individual's gut microbiome. Dietary factors, for example, infant feeding, whether a baby is breastfed or formula fed, can impact on the microbiome. Medications, for example, antibiotics, may affect it. And even with anti-epileptic drugs, it's found that they have exerted some effects depending on which can affect the efficacy of medications as well as infection. And many of these relationships tend to be bidirectional. So one of the modalities to modify the gut microbiome is fecal transplantation. This has been used in other neurological disorders and is being investigated in multiple sclerosis and in patients with autism. But in epilepsy, only a few transplant case reports exist. And the one that's commonly cited in the literature is that of a patient who received a fecal transplant for Crohn's disease. But the patient was also known with relatively well-controlled epilepsy. The patient was noted to have a few seizures each year, which seemed to be associated when she defaulted treatment. After the fecal transplantation, The patient had stopped taking her anti-seizure drugs and found that she had no seizures for the following 22 months, pointing towards a potential therapeutic option with fecal transplantation. Probiotics is a less invasive alternative to fecal transplant, and introducing probiotics, which are good bacteria, or prebiotics, which are food for good bacteria, to the human gastrointestinal system via tablet can be used. Preclinical studies have found that probiotic supplements dramatically reduce seizure severity in chemically kindled rats, and rats given the supplements and decreased levels. Rats given supplements have shown decreased levels of markers of oxidative stress, as well as increased levels of GABA. A single published clinical trial on probiotics in refractory epilepsy was a study conducted by Gomez et al. And it was a pilot study in 45 patients with drug-resistant epilepsy. And what they found is that patients exhibited a reduction in seizure frequency of more than 50% in 29% of their cohort. 77% of these patients maintained their reduced seizure frequency 4 months after discontinuing their probiotic. They also reported higher quality of life scores. Another study, which looked at infants who were infected with rotavirus and developed seizures, looked at when the probiotic was administered. So they looked at infants who had a probiotic administered 24 hours after birth, and those who were administered the probiotic after they developed infection with rotavirus. And what they noted is that infants who were administered probiotics early or within 24 hours of birth showed a reduced adjusted odds ratio to 2.4 of seizure risk than those who received probiotics after 24 hours, and they maintained a higher odds ratio of developing seizures. So the thought process behind this is that could early administration of probiotics or preemptive administration actually have a greater impact? Antibiotics tend to be the most potent disruptors of the microbiome homeostasis, and they're implicated in both the etiology and the treatment of seizures. Antibiotic-related seizures are infrequent, and they're seen most often with beta-lactams. These drugs may lower the levels of some anti-epileptic drugs or alter the gut microbiome and result in seizures. A study by Brackman et al. Reported that 5 out of 6 patients with drug-resistant epilepsy became seizure-free during antibiotic treatment, and 1 of the patients had a significant reduction in seizure frequency. Improvement was sustained for 2 weeks after the antibiotic treatment was sustained, leading to the thought that there may be a beneficial effect that is mediated by antibiotic alterations in the gut microbiome. The ketogenic diet is an alternative dietary therapy to the treatment of epilepsy. It's a non-pharmacological intervention used particularly in pediatric populations with enzyme deficiencies. It consists of a high consumption of fat, moderate protein intake, and a very restricted carbohydrate intake. And the hallmark of the diet is the production of ketone bodies to prevent seizures. It is highly effective in the treatment of resistant epilepsies, and various mechanisms are thought to contribute to its effectiveness. But current evidence suggests that the anti-epileptic effect of the ketogenic diet may be attributed to changes in the gut microbiome. Diet-induced changes in the gut microbiota tend to be reproducible and persistent in patients who have undergone a ketogenic diet. A landmark preclinical study done by Olson et al. Showed that the ketogenic diet altered the gut microbiota across 2 seizure models, and that changes in the microbiome are necessary and sufficient for conferring the seizure protective effect of the ketogenic diet. The diet reduced microbial alpha diversity. It increased the abundance of certain gut species. And what they found in animal models who were reared germ-free, they tended to be resistant to the seizure protective effect of the ketogenic diet. However, when these germ-free animal models were then colonized with the gut microbial flora, they demonstrated a benefit to the ketogenic diet, leading to the thought that the gut microbiome is essential for the effectiveness of the seizure effectiveness of the ketogenic diet. So gut microbiomes modulate seizure susceptibility through mechanisms that do not involve beta hydroxybutyrate levels or ketosis. And there are associated elevations in GABA relative to the glutamate content, which has been demonstrated in animal model hippocampi. There have been several clinical studies which also looked at alterations of the gut microbiome in patients on the ketogenic diet. There are several studies which have been done, particularly in pediatrics. Z et al. Looked at 14 patients with drug-resistant epilepsy, and overall, they compared this to 30 controls. Overall, what was found is that there was a reduction in the pathogenic proteobacteria that was noted, and an increase in the beneficial bacteroides after commencing the ketogenic diet as early as 1 week after starting the diet. And this correlated with the suppression of seizure activity. Zhang et al. Found that, again, there was reduced levels of certain bacteria phyla, for example, Firmicutes and actinobacteria, and increased levels of bacteroides after the treatment. And it's thought that these bacteria might modulate serotonin levels and inflammatory pathways to influence brain function and seizure control. Linderfeld et al. Also did a comparison in patients on ketogenic diet between controls and drug-resistant patients, and again, demonstrated an increase in certain phyla, particularly bacteroides and proteobacteria, which have been implicated. Going on to drug-resistant epilepsy, intestinal dysbiosis itself may contribute to the mechanism of drug-resistant epilepsy. There are differences in the gut biomes of drug-resistant epileptics compared to those who were responsive to anti-epileptic drugs and healthy controls. And what it's been found overall is that drug-resistant groups tend to have rarer bacterial species. Studies done by Peng et al. Compared the microbiome of fecal samples from drug-resistant, drug-sensitive epileptics and compared these to drug-resistant epileptic patients and healthy controls. The results have been inconsistent across studies, but what has been found by Peng et al. Was that there was an increase in alpha diversity in the drug-resistant epilepsy group and an increased abundance of Firmicutes and other rare microbiota. Patients who had fewer seizures or less than 4 seizures a year tended to be similar to drug-sensitive patients and controls, and had greater predominance of phyla such as Bifidobacterium and Lactobacillus. And it's thought that metabolites from both Bifidobacterium and Lactobacillus have been associated with an increase in GABA synthesis and thus are seizure protective. Gong et al. Instead did a similar study, but found a decrease in the alpha diversity gut microbial composition. Another study, which looked at 14 infants with medically refractory epilepsy, again found instead correlated with Peng et al. And found a reduction in bacteroides and actinobacteria and an increase in Firmicutes and proteobacteria. Linderfeld et al. Also looked at drug-resistant epilepsy and demonstrated a reduced alpha diversity and a larger variation of the microbiome. So although results have been inconsistent across all studies, what it's been found is that drug-resistant epileptics tend to have a more dysbiotic gut microbiome compared to patients who have got drug-sensitive epilepsy. And drug-resistant epileptics tend to have an increased abundance of rare gut microbiome. This table just summarizes the studies that I've just gone through. I'm not going to go through it in detail. To end off, the future directions. Where are we heading with the gut microbiome brain axis and epilepsy? So gut microbiome profiling could potentially serve as a biomarker in epilepsy management. Alterations in gut microbiota in drug-resistant epilepsy could be used in clinical practice in order to identify drug resistance and use targeted interventions. Future research may establish whether altering bacterial composition may serve in the management of refractory epilepsy, and there's a need to expand the research of gut dysbiosis as a contributor to epileptogenesis beyond just drug resistance. So in conclusion, there's a bidirectional communication network which exists between the gut and the brain. There are 5 routes of communication between gut, microbiota, and the brain. The gut microbiome plays an important role in human health and disease. There's evidence for a difference in the enteric microbial composition between refractory epileptics and non-refractory patients. Newer sequencing methods for microbial characterization has transformed the microbiome research as well as the axis's functional impact on health and disease. Understanding the role of the gut microbial brain axis in drug-resistant epilepsy could lead to personalized medicine in the future and potential therapeutic targets. Thank you.
Thank you very much, Dr. Nido, for very, very comprehensive, nice talk. Really, I really enjoyed it. I'm looking at question and answers. I don't see any question, but I have a question myself as a pediatric neurologist. And you mentioned a lot about rule of ketogenic diet and hopefully how it's helping in a patient who had epilepsy. And I was like really myself interested in gut microbiomes and epilepsy. And my question is, because we are using the ketogenic diet on a daily basis for patients who had refractory seizures, and we see it like really effective in a lot of patients that we are using it. It's processed. Sometimes you need to bring the patient in the hospital, stay for 5 days, and it's long process, monitoring many things. I'm really looking, do you think that one day will come like one tablet consists of this microbiome and you can give it to these kids or any patient who had epilepsy, and it will help instead of putting them through all of this process of doing the ketogenic diet?
Yeah, I think we all, as treating physicians, would definitely hope and wish that it would come to that one day. I think we're all familiar with the challenges, particularly in pediatrics, of introducing that diet and maintaining such strict dietary control, as well as you mentioned, the monitoring of young patients. I'm not certain if we'd actually get to that point. I think my personal feeling is that I think the ketogenic diet, its effectiveness is on various mechanisms, not just the gut changes in the gut microbiota. But I certainly think that it may influence the microbiome and contribute to the reduction in seizure frequency. But I don't think that the microbiome changes itself are the only contributing mechanism with the ketogenic diet. So I'm not sure if we would be able to condense that diet into a tablet. But certainly the hope is that perhaps dietary supplements like medium chain fatty triglycerides, oils, supplements, which are used in the diet, can perhaps make it a bit easier for patients to tolerate the diet.
Okay. I have a question here from Dr. Arwa. She's asking, thanking you for a great talk, and she's asking, are there clinical symptoms in epileptic patients with pharmaco-resistant epilepsy in favor of gut dysfunction, like diarrhea, constipation, abdominal pain, or is it just always subclinical?
I think the research is not out there at present. From my reading, most of the research is preclinical. And from what I've seen in the literature, I have not come across symptoms being described. I think it's a good point to raise. And in my clinical practice, I have not seen it either amongst the epileptic patients. But perhaps it's something that we need to look at or look out for. Because like I say, this is something very new and topical. And I think most of the publications that are out at present, a lot of it is laboratory based and not clinician or physician based. So at present, the answer to the question is no. But I would hope that the physicians in the audience would look out for it in patients. Maybe it's something that we are completely unaware of. Yeah.
Okay. I don't see any other questions. It's really illustrated very clear, Dr. Nido. Really thank you for very nice talk. And now we can move to our next speaker. It's really my pleasure to introduce Dr. Ghaib Jandil. Dr. Ghaib Jandil is a consultant epileptologist and clinical neurophysiologist. Dr. Jandil is a graduate of Baghdad Medical College and King's College London. He is a senior lecturer and member of teaching faculty of Iraq Council for Medical Specialization in Iraq, boards of neurology and pediatric neurology and clinical neurophysiology. He supervised the video EEG monitoring at UNIT in Baghdad Teaching Hospital. And Dr. Jandil is Secretary General of Iraq League Against Epilepsy. He was a member of SEMA from 2013 to 2017 and from 2017 to 2021. And currently, we are pleased to have him chair of International League Against Epilepsy, Eastern Mediterranean region. Dr. Ghaib is going to talk to us today about sleep and epilepsy. So the mic is yours.
Thank you, Dr. Ghaib, for this nice presentation. Really, I am presenting now a short lecture of 35 minutes about sleep and epilepsy, which is an ancient and old subject, in contrast of the subject of Dr. Subclinical, which is a very new one. My lecture is recorded and it's sent to Jessica. I think it will be presented now. Waiting for your questions after the end of the lecture. Good night for you all. Our lecture today would be the sleep and epilepsy. Three domains in this lecture would be presented: introduction to sleep, effects of sleep on EEG, and effects of sleep on epileptic seizures and syndromes. What is sleep? Sleep is a reversible behavior state of perceptual disengagement from the environment with unresponsiveness. Two major parts in sleep, really: non-REM sleep or non-rapid eye movement sleep, and the REM sleep, rapid eye movement sleep. The non-REM sleep, a relatively inactive brain in a movable body, while the REM sleep, a highly active brain in a paralyzed body. Two definitions, very simple. Relatively inactive brain in a movable body for the non-REM sleep, while active brain in a paralyzed body in REM sleep or sleep with dreams. Sleep distribution, normal young adult, there are these two stages of sleep are constituting for the non-REM sleep 75%, while the REM sleep 25%. The 75% are distributed among the four stages. Stage one being the shortest, usually at the very beginning and the very end of the sleep time, while stage two is the longest stage in non-REM sleep, about 45%. Stage one and stage two, both of them are named as light sleep, while stage 3 and 4, which constitute 25%, are called the deep sleep. The REM sleep is 25% of the whole time of sleep. Normal sleep pattern, there is an alternation of non-REM sleep and REM sleep during the night. In 90 to 120 minutes or 1.5 to 2 hours in one cycle, and it will be for 4 to 6 cycles per night. Most slow sleep, stage 3 and stage 4, are in the first third of night, while the REM sleep usually is in the second half of night. REM sleep latency, 90 minutes after sleep, onset at the start of sleep. Later on, it will come again and again in a shortest time during the sleep stage during the night. EEG of drowsiness, stage 1 sleep, there will be disappearance of eye blinks, onset of slow eye movements, and occurrence of theta activity over the posterior regions and attenuation of the alpha activity. Here is an EEG in wakefulness where we see this alpha activity while the eyes are closed, and we see this beta activity while eyes are opened, and this is a normal for an adult person. In stage 1 sleep or drowsiness, which is the other name of stage 1 sleep, there will be absence of the eye blinks, as we see. There will be this emergence of slow movement of eyes here and here. And we see the theta activity or the attenuation of alpha at the posterior region. Again, another picture where the theta activity is more evident. The slow waves are seen evidently with the absence of eye blinks. Still in stage 1 sleep, we have vertex sharp transients, and we have the positive occipital sharp transient of sleep called BOST, named as BOST, which are normal transient in sleep. The positive occipital sharps or BOST, similar appearance to the lambda waves, which is usually seen in a wakeful state, and are mainly seen during drowsiness and light sleep. EEG in drowsiness or in first stage of sleep, we will see the positive occipital transient of sleep, and we will see this vertex waves, and this is the BOST waves. BOST here coming in succession, in a series. Well, stage 2 sleep, we have two important items: the sleep spindles and the K complex, which are the hallmarks really of sleep stage 2 sleep. Sleep spindles, a frequency of 13 to 14 Hertz, symmetric usually on and synchronous over the two hemispheres in adult. Intervals between 1 and the second, 5 to 15 seconds between the first one and the second one. This is the sleep spindle seen here. Sleep spindle. Again, sleep spindle. Here is a better view of sleep spindle in this part, and sleep spindle here, and the vertex sharp waves in this part. K complex, a broad diphasic or polyphasic wave, more than 500 milliseconds, half a second, may be linked to an arousal response. This is the K complex, slow, high amplitude slow wave, intermingled with sleep spindle. Again, this is the K complex, high amplitude sharp wave with this sleep spindle, and we see also the sleep spindle alone. Here, a combination of high amplitude sharp wave and sleep spindle to constitute the K complex, which is believed to be an arousal state. And this is the sleep spindle alone. Here, sleep spindle, and we see maybe sometimes the vertex waves. Well, slow wave sleep, our stage 3 and stage 4. This is stage 3, where mainly the theta activity and some delta. There is absence of alpha, absence of beta, and the stage 4 of slow wave sleep, where mainly the delta activity. Here, sensitivity, of course, is reduced. Usually, it is a high amplitude and cannot be visualized really, but there is reduction in the amplitudes. Well, the REM sleep or rapid eye movement sleep, we will see this rapid eye movement, which it derives the name from this rapid eye movement, where there is rapid eye movement in the with this electrical artifact. It's not a mechanical artifact, it's an electrical artifact, because the eye is a dipole with negativity from inside and positivity from the outside. When it this movement, it will cause this electrical changes seen here as you see here. And we will see also the vertex sawtooth, which is the characteristic of rapid eye movement sleep EEG. And as you see, it might be similar to some extent to the wake EEG, where the patient is, or the person is experiencing dreams. So the brain is active, seeing and hearing and speaking, etc., with this wakeful, similar to a wakefulness EEG. Well, the reticular activating mechanism, RAM, the brain usually is maintaining the wakefulness through this RAM or reticular activating mechanism by activity coming from all the sensory modalities via brainstem, reticular formation, and thalamus, and then to the cortex to keep the mind awake, the brain awake. And we have the arousal inhibitory mechanism. The brain transfers from wake to sleep by means of the arousal inhibitory mechanism, where the sleep spindles, as you see here, play a role in this process in blocking partially the activity coming from the modalities and will block from continuing to go to the cortex and will try to put the cortex in a resting stage or an inactive stage. Well, this sleep stage in a schematic presentation, where we see this is the yellow, this is the awake level, and this is the stage 1, light blue, and stage 1 here. At the very beginning, at the very end, it only constitutes 5%, almost about 5%. While stage 2, this one here and here, constitute more, about 45. Stage 3 and stage 4. So from stage 1 to stage 2 to 3 to 4, then we will arrive to the REM sleep, rapid eye movement sleep, after about 1.5 an hour or 2 hours or lesser. And you see here the stage 4 is seen in these 2 places, where it is in the first third of night. It will disappear later on, and it only deep sleep will be only as a stage 3 throughout the night. As we are going towards the morning or going deep in sleep, we will see that the REM sleep is increasing in quantity, and later on it will stay only the REM sleep and the stage 1 and the stage 2, stage 3, I mean, and the stage 2 and the stage 2 and REM sleep. So light sleep and REM sleep. And this place in the morning, usually we find this REM sleep and the light sleep together, while the patient will be easily awakened. And if he awakened, he will remember his dreams that were taking place during his sleep. Well, so the REM sleep lengthens over the night, as we see here, and the nuclei responsible for sleep are the suprachiasmatic and the preoptic nuclei of hypothalamus that are regulating the sleep cycle. The ventrolateral preoptic area is important for the control of sleep. Lesions of this area produce total insomnia, leading to death in experimental animals. The second domain of the lecture are the effects of sleep on EEG. Sleep EEG recording is highly recommended really to recognize nocturnal seizure among complex nocturnal behaviors. In certain epilepsy syndromes, EEGs are fully normal on wakefulness, whereas interictal and possibly ictal discharge appear during sleep. So sleep recording is fundamental. Does sleep activate abnormal EEG discharge? Yes. Epileptiform discharge are generally more common in slow sleep than REM sleep than in REM sleep. Interictal discharge are more activated during deep sleep, stage 3 and 4, while the ictal discharge are usually activated during initial stage of sleep or light sleep, stage 1 and stage 2. That's why we see usually the nocturnal seizures, when they are focal, are seen at the very beginning of sleep, after few minutes after the patient going asleep. Well, during non-REM sleep, there is reduced input from the brain stem, the reticular activating system, leading to progressive hypersynchronization, facilitating then the interictal epileptiform discharge. This interictal epileptiform discharge will be implanted or will be encouraged during this hypersynchrony of sleep. This is an example of sleep activation. We have, this is a wakeful state with dipole or Orlandic spikes seen in the right centrotemporal region here and here, and we see the phase reversal at the central region. This is usually seen in the benign Orlandic epilepsy or self-limited epilepsy with centrotemporal spikes. And during sleep, there will be activation of these centrotemporal spikes and will be seen bilaterally on both sides and seeming as if they are generalized. Well, another place where sleep play a role is the hypsrhythmia, which is a chaotic high voltage, regular slow waves with variables synchrony, of course. Absences there will be of all normal activities. It will be very disorganized. Hypsrhythmia is continuous in wakefulness and light sleep, but it is discontinuous in deep sleep and it will disappear in REM sleep. So this modification of sleep on hypsrhythmia, it will disappear during REM sleep. it will be discontinuous, and we call it modified hypsarrhythmia in deep sleep, but it will be continuous and wakefulness and possibly in light sleep. This is an example of hypsarrhythmia during wakefulness with a continuous, non-interrupted activity, high voltage activity. This is with normal sensitivity. If we reduce the amplitude, we may see it in this picture. This is the same picture with highly reduced activity, and we will see even the sharp, the focal activities here and there. This is during wakefulness again with lower sensitivity. This will be during non-REM sleep, where we see some sort of interruption starting to interrupt the activity, the continuity of the hypsarrhythmia. Here, even better, we will see the hypsarrhythmia in a manner which is very similar to birth suppression. But this is not birth suppression, of course. And this is again hypsarrhythmia like birth suppression, where there's interruption made by slow sleep. And this is termed usually modified hypsarrhythmia. Well, still in effects of sleep on EEG, there will be emergence of non-epileptic epileptiform discharge during sleep. They are epileptiform because they are resembling epileptic discharge, but they are non-epileptic because they are of no significant pathogenicity. Well, one of them is the rhythmic mid-temporal theta of drowsiness, what we see here, mid-temporal region. It seems to be as if it is focal activity. Then we have the wicked spikes here, spikes. We have the benign epileptiform transient of sleep here and here, or small sharp spikes, same name. This is the small sharp spikes. We have then the wicked spikes in a succession, as a burst, not like not as a transient. And we will see the psychomotor variant epileptiform non-epileptic discharge. Also, we may see this the hypnagogic hypersynchrony, where there is building of slow activity in a generalized manner, and usually as the patient or the person going to deep sleep. Here in this, there will be some, there is a jerk here. There is a jerk or hypnic jerk, sleep myoclonus, which is again one of the effects of sleep on the person. And this we see on a normal event. EEG-wise, we only see the artifact of this movement. Well, now the third domain, the effects of sleep on epileptic seizures and syndromes, and then the effects of epileptic seizures and syndromes on sleep. Sleep and epilepsy syndromes, about 20% of epilepsy syndromes occur exclusively at night. Self-limited epilepsy with central temporal spikes or the benign type, usually occurring during sleep in more than 90%. There are, of course, more than one presentation of this type of epilepsy. And we have the binotubulous syndrome. About 70% plus minus occur during sleep. The new name is of it is the self-limited epilepsy with autonomic features, implying that it is not necessarily occipital. It is there will be autonomic symptoms, and this autonomic symptoms may be the only features sometimes. Usually that lasting more than 30 minutes, and when they start or last for more than 30 minutes, they may constitute status epilepticus. And really one of the most common non-convulsive state of epilepticus in children is this type of paraneoplanus syndrome, where there is no convulsion but this autonomic features. Ictal discharge, why in light sleep, stage 1 and stage 2? State will be the state of reduced local connectivity and diffuse disconnection in the neurons during light sleep. This may be responsible for the epileptogenesis or for the emergence of ictal EEG discharge. Well, West syndrome, one of the where sleep play a role, with a triad of infantile spasm, intellectual disability, and specific EEG pattern hypothermia, as we said before. Sleep will cause fragmentation of discharge, that's modified hypothermia. Hypothermia again interferes with the physiologic decrease in slow wave of non-REM sleep and therefore disrupt memory consolidation. So the sleep will cause fragmentation of this activity, and this activity or hypothermia will cause a decrease or a modification in the sleep type of or in the efficiency of sleep. The slow sleeps will decrease, and therefore there will be disruption of memory consolidation. This is maybe seen in more than one place, not only in hypothermia, but in other places, and we will see in a while. Lennox-Gastaut syndrome, again, one of the places where this sleep play a role. Multiple seizure types, as you know, we have the tonic seizure during sleep with characteristic multiple spike EEG. The characteristic finding in Lennox-Gastaut, tonic seizure during sleep. Again, there will be disruption of sleep with increase in arousals, increase in light sleep, and decrease in slow sleep, similar possibly to hypothermia effect. And then decrease in memory consolidation. Sleep effects on childhood absence epilepsy. There will be fragmentation of classical spike wave into pairs and the transient instead of runs. And this pairs or runs or transients will be, there will be preference to transitional stage between wakefulness and sleep cycles and between the stages of the non-REM sleep. This is a picture of absence during wakefulness. This picture will be interrupted and will be as form of pairs or transients when occurring during sleep. JME, sleep usually affects the JME, where the bright sleep will activate JME, and it usually occurs 2 hours after awakening, while JME again affects sleep, and there will be more insomnia, more daytime sleepiness, and there will be prolonged REM latency and prolonged REM duration. So there is a exchangeable effects on between the seizures and between the sleep time or efficiency. Electrical status epilepticus during slow wave sleep or ESES syndrome, continuous spike wave activity noted during sleep, which usually disappear on awake state. We will find continuous spike and wave in the form of state of epilepticus only during sleep. Once the patient awaken, this status will disappear and will be replaced by a normal activity or by a sporadic abnormalities here and there in the record. There will be different kinds of seizures in this syndrome, partial and generalized, but no tonic seizures, which differentiate it from the Lennox-Gastaut. Tonic seizures with multiple spikes, which seen usually during nocturnal time, nocturnal seizures are differentiating Lennox-Gastaut from the ESES syndrome. Classically, the spike wave index of more than 85 during the non-REM sleep is found here in ESES encephalopathy or ESES syndrome. And this is an example of this status, electrical status during sleep. And this will be full in the recording during night sleep. And more than 85% really of the, sometimes even up to 95 or 100%. Landau-Kleffner syndrome or acquired epileptic aphasia, spike wave index here is lesser than 85%. And again, we will find sleep, electrical status epilepticus, but there will be normal imaging, normal development prior to the onset and reaching language milestones very normally. Then later on, loss of language skills. Also, there will be lesser number of seizure or no seizure at all. Aphasia attributed to here in this syndrome are attributed to the auditory agnosia, when the patient can hear but cannot designate what the meaning of these words. The picture may improve with EEG normalization later on. Focal epilepsies, generally seizures arising from temporal lobe occur more often from wakefulness, and this is practical. Temporal lobe usually seen during wakefulness, whereas those from the frontal and parietal lobes occur more often during early non-REM sleep. One of this picture is the benign Rolandic, when it is, which is of course frontal lobe epilepsy, is seen during the first stage of light sleep. Among the frontal lobe seizures, those from the supplementary motor area may occur during both sleep and wakefulness, whereas those from the prefrontal or vitofrontal occur during non-REM sleep. Nocturnal frontal lobe epilepsy, which is now changed name to sleep-related hypermotor epilepsy, which imply that it is not necessarily frontal origin. Nearly all seizures occur during non-REM sleep, stage 2. Interictal EEG is always normal, and the surface EEG may even fail to capture ictal events in this type of epilepsies or seizures. So a challenge really will be found to differentiate them from sleep disorders. Well, sleep-related hypermotor epilepsy, there are really 3 main forms of semiology we will not go through, but all these 3 types are stereotyped, one of the characteristics, stereotyped in the same patient, and may manifest during different times, and they are usually frequent. The variability in semiology may be due to the length and the duration of the pathway of propagation from the seizure onset zone. Main parasomnias of non-REM sleep, we have mainly the confusional arousals, the night terrors, the sleep walking. Well, the confusional arousals, sudden awakening from stage 3 or 4 non-REM sleep, and in a confused state, no scream as seen in terror, and can mimic temporal or even frontal seizures. Night terror, usually from stage 3, with extreme fear and tachycardia, and a scream, mimics temporal seizures. Sleepwalking starts in non-REM sleep stage 3, complex automatism, can resemble a frontal lobe seizure. Parasomnias of REM sleep, we have the nightmares, the REM sleep behavior disorder, and the sleep paralysis. These are the main types. The nightmares or bad dreams, dreams that are scary and frightening. And we have the REM sleep behavior disorder, where there is failure of muscle paralysis in the REM sleep, resulting in acting out of dreams. There will be REM sleep and there will be dreams, but there is failure of muscle paralysis. There will be tone will be still found, and this may lead to really some dangerous events, because fear may drive the patient to run away or attack others, and this is really a familial disorder. And here the seizure may resemble temporal or frontal lobe seizures. Sleep paralysis, inability to move with difficulty in breathing from resisting REM paralysis. Here is the controversy of the first REM sleep behavior disorder. There is here the REM sleep is persisting. There will be paralysis, sleep paralysis. The patient will be awakened. The sleep is ended, but the sleep paralysis of the REM sleep is still found. So the patient is awake but cannot move his body, stay for a while. On the contrary of the first one of REM sleep behavior disorder, where the patient muscle paralysis, there will be failure of muscle paralysis while the sleep still continuing on. Well, epilepsy versus parasomnias of non-REM sleep. Clinical picture of sleep-related hypermotor epilepsy may overlap with parasomnias, with confusional arousals, with sleep terror, with sleepwalking, both of the non-REM sleep. Parasomnias share initiation from stage 3, difficult to be awakened during the event. Amnesia to the event is a universal feature. Parasomnias less frequent than seizures, usually 1 per sporadic night or 4 times per month, whereas seizures are multiple per night, every night. Non-rapid eye movement sleep parasomnias not associated with hyperkinetic automatism, and something similar between the two is the dystonic posturing, which occur in both in seizures and in parasomnias. Well, epilepsy versus REM sleep behavior disorder, both occurs at the second half of night. Seizures are less common than in non-REM sleep. Of course, in this type of sleep, the seizures are less common. Not stereotyped. This is, I mean, the sleep disorder. While the seizures are stereotyped, eyes are closed, while in seizure the patient awakens abruptly, opening eyes during the event. Well, in conclusion, sleep and epilepsy have reciprocal effects. Sleep is fundamental for epilepsy diagnosis, for epilepsy classification, and for epilepsy management. Epilepsy diagnosis, because there are a lot number of seizures or syndromes, we need sleep to diagnose, to make full diagnosis. Classification, again, we need the sleep to go further for further classification after diagnosing epilepsy. And for epilepsy management, again, we need, say, for JME, for example, we need full sleep to obtain to obtain some sort of relaxation. Well, among epilepsy syndromes, we have the self-limited epilepsy with central temporal spikes, and paratubular syndrome, self-limited epilepsy with autonomic features have seizures that occur more often during sleep, whereas AME occurs after deprived sleep, usually 2 hours after awakening when it occurs. Non-REM sleep parasomnias occur more frequently from stage 3, do not manifest hyperkinetic automatism, they are not stereotyped, and are less frequent than seizures per night. Disturbed sleep, less efficiency, and decrease of slow wave sleep usually seen in Lennox-Gastaut syndrome, in infantile spasms, and in focal epilepsies. That is the end of the lecture. Thank you very much. We are now ready to hear your questions.
Thank you very much, Dr. Ghaib, for very comprehensive and interesting talk.
Yes.
So we can have questions. Anyone had any questions? I don't see any question, but maybe I can ask you a question, Dr. Ghaib. You mentioned regarding frontal lobe epilepsy, sometimes the EEG will be normal. And so how can you differentiate it from non-epileptic events?
Well, this is really a challenge. There's a known challenge from long time that frontal epilepsies not necessarily that through the interictally usually it is normal. That it's usual. A lot of seizures or epilepsies interictally are normal. But the problem with the frontal lobe is that during the ictal phase, the activity, the EEG sometimes is not capturing the abnormality. That's one. Second thing, the presentation of frontal lobe itself is again not very far from the, say, non-epileptic, from the hysterical, from the, because there's a challenge in the semiology, a challenge, and then the EEG, a challenge. How do they differentiate? There are a lot of ways, either, of course, to repeat and repeat again to reach the proper, but you find the stereotyping in frontal lobe epilepsy. The seizure will be similar during the night, while there is difference stereotype in the sleep disorders. That's one. It's usually frequent types, frequent in number, per one night, 3, 4, 5, etc. While it is sporadic only during, usually frontal lobe disorders are in a younger age, usually in the childhood. Frontal lobe maybe, of course, all the ages, but it's usually in the young and in adults. But mainly you have to repeat again and again until you capture, by the video EEG study, you will capture definitely one day this seizure time or this diagnosis.
Thank you very much. So if we do like capture some of these seizures or events, it will. Could it, sometimes even if you capture it, nothing can happen in the EEG. You may not see any EEG changes correlate with these events.
Yes. But this is, I told you, it is a challenge. Even the ictal changes are not always similar. Ictal changes, different from the interictal changes. Interictal changes, you will find spike and wave, you find bell spikes, you find the slow spike and wave, I mean generally in seizures or in epilepsies. The ictal may be just delta activity, maybe just theta activity starting, maybe just a decremental pattern. It may the different types or different forms of electrical activity the ictal activity can be in such different forms of changes. At the same time, the clinical picture of the frontal lobe is always query and challenging. But you have to repeat again and again in telemetry or in long-term studies. Usually the patients stay alert several times in order to, and you take, of course, other situations, other pictures, the clinical picture at all. Always in diagnosis of seizure and epilepsy, we have to take the full clinical picture, and we go then further to the EEG, so that it will lighten the picture to us and will lead us to further step in the form.
Thank you so much.
I believe that there is a lot of questions, but I don't know why. Maybe today Iraq, I think the internet is not very good. A lot of friends really contacts me that there is not able to go to attend.
Yeah, I think your talk was really clear. Maybe they don't have a lot of questions because it was very clear.
Yeah.
If there is no more questions, this is the end of today's webinar. I would like to thank the organizing committee of Eastern Mediterranean region, especially the Dr. Fatima Abdullah, who is always taking the burden and organize this wonderful activities. Also, I would like to thank the speakers, Dr. Ghaib and Dr. Nido, for really wonderful, comprehensive talks. I would like to thank you all, the attendee, for listening. And inshallah, we'll see you in the near future in other webinars. Thank you very much.
شكرا جزيلا.